Welcome to the Curvafix Masterclass featuring an expert panel of key thought leaders discussing use of the novel Curvafix IM implant and the current challenges it helps to overcome in pelvic trauma surgery. My name is Dave Briggs, and it's my pleasure to open tonight's session. We have a truly exceptional group of outstanding speakers who present early U.S. clinical experience with the only device to follow natural bone shape and fill the space within curved bones, such as the pelvis, to facilitate a new approach for pelvic fracture repair. Before we begin, one reminder, be sure to make frequent use of the Q&A button at the bottom of your screen. Thank you for joining us this evening, and it is my pleasure to introduce the moderator for tonight's symposium, Dr. Milton Lee Rout, also known as CHIP, the Dr. Andrew R. Burgess Endowed Chair and Professor of Orthopedic Surgery at the University of Texas McGovern Medical School at Houston, the Texas Trauma Institute, and Memorial Hermann Hospital, Texas Medical Center. Dr. Rao currently serves as the President of the Surgeons Council and co-chairman of the Quality Assurance Committee, and he is on the Medical Executive Committee at Memorial Hermann Hospital, Texas Medical Center. Dr. Rao, the floor is yours.
Thank you, David, for that very kind introduction, and thanks to all of our attendees tonight. We have an expert panel of highly experienced orthopedic surgeons with us this evening, including Dr. Amir Metiyahu, Dr. Carl Van Osten, Dr. Josh Gary, Dr. Samir Mehta, and Dr. Robert Meek. During the master class tonight, we will discuss some of the current trends and challenges in pelvic fracture fixation and share more about how this novel, flexible device was developed and launched by Curvafix to address some of these challenges. We will also hear from experts about how the Curvafix implant is being used with pelvic and acetabular fractures in patients. I'd like to introduce the faculty. Dr. Robert Meek. Believing there was a better way to repair pelvic fractures, Dr. Robert Meek is the visionary behind the Curvafix concept. He currently chairs the Curvafix Surgeon Advisory Board and is a clinical professor emeritus at the University of British Columbia, where he founded and became the first head of the University and Vancouver General Divisions of Orthopedic Trauma. Dr. Meek will be speaking to us this evening on the development of the curved pelvic implant. Dr. Amir Metiyahu. Dr. Amir Metiyahu is presently the Chairman of Surgery, Chief of Orthopedics, Director of Orthopedic Trauma at Regional Medical Center of San Jose, and the Director of Pelvis and Acetabular Trauma Reconstruction at San Francisco General Hospital. He is a professor in the Department of Orthopedics at the University of California, San Francisco. Dr. Metiyahu will be speaking to us this evening about the post-market restore study using the Curvafix implant. He will also present 3 of his recent cases, including one using the implant in a patient with a dysmorphic upper sacral segment. Dr. Carl Van Osten. Dr. Van Osten is the director of the Orthopedic Trauma Service at the North Mississippi Medical Center in Tupelo and a restore study investigator. Dr. Van Osten will be speaking to us this evening about a case where he used the Curvafix implant to repair an acetabular fracture. Dr. Joshua Gary. Dr. Gary is the chief of the Orthopedic Trauma Service and an associate clinical professor of orthopedic surgery at the Keck School of Medicine of the University of Southern California. Prior to joining Keck, Dr. Gary was using the Curvafix implant in the restore study at the University of Texas Health Science Center in Houston, Texas. He will be speaking this evening about using the Curvafix implant for superior pubic ramus fixation. Dr. Samir Mehta. Dr. Mehta is the chief of orthopedic trauma and fracture care and an associate professor of orthopedic surgery at the Perelman School of Medicine at the University of Pennsylvania. He will present a case where 2 Curvafix implants were used in a polytrauma patient with a lateral compression pelvic injury and a parasymphyseal fracture. A few housekeeping notes. We'll be keeping track of your questions, and your panel will look forward to answering them during our Q&A session after the case presentations. Please let us know if your question is for a particular surgeon. In addition, Steve Dimmer, Curvafix CEO, will be joining the panel for any questions about the company. To get things going, I'd like to open with a short presentation on some of the challenges in pelvic fracture fixation. My topic is pelvic fracture fixation, and especially dealing with the challenges and the problems that face us as we're trying to take care of these problems. My name is Chip Rout. I'm the Dr. Andrew R. Burgess Professor and Endowed Chair at the University of Texas Health McGovern Medical School in Houston, Texas, and I work at Memorial Hermann Hospital and the Texas Medical Center as an orthopedic trauma surgeon there. My disclosures are that I do speaking for AO North America, do teaching also for Diffuse Synthes, Stryker, Zeem, Zimmer, and have been involved in the Curvafix product as well. So when we deal with the problem of traumatic pelvic injuries or pelvic fracture fixation, and when you pull back from it, especially if you look at and reflect back over the last 30 years, a lot of progress has been made, but there are still significant challenges and problems and issues that face all of us, regardless of our age or regardless of our experience or any situation that we might be in. And there are really rough roads ahead of us just about every time that we take care of a patient with an unstable pelvic ring injury, and the fixation is a big part of it. And I would say that if you boil it down, really the problems that occur are either with the patient, with the surgeon, his or herself, and then the institution. I'm not going to talk about institutional problems. That's a whole nother set tonight. Tonight, we're just going to take care of just the patient and the surgeon issues, at least as I see it, in my opinion. So the challenges and problems that go along with taking care of patients, I think that all of you that do take care of patients are very aware of the things that really face us each day as we're caring for patients, especially doing orthopedic trauma. And probably the thing that vexes me the most and continues to really be the rock that I try to push uphill is just the complexity of the injury patterns. The complexity of the injury patterns, I think, over the past 3 decades has really gotten more and more severe or more and more complex. And I believe it's because of a lot of reasons. And probably the main 2 reasons are that the resuscitation in the field and the transport and the resuscitation and the initial management of the patient in the emergency centers has gotten to be so much more refined than it was. And it just continues to get better and better and better as different techniques and modalities are involved. So we're seeing much more complex injuries than we used to, because I think a lot of people survive when they used to not survive at all. We also know as clinicians that it's not just necessarily the bone complexity of the injury patterns and sort of, devolving down to the Burgess, the Young and Burgess classification scheme or the AO classification scheme, but really it's, the whole situation with the patient. And it can be, open injuries or even closed soft tissue injuries that make things even more complicated for us. And here you can see just an open perineal wound, not very extensive, certainly not bleeding from it at this point. And but again, still a little bit of a challenge from a management standpoint because of the contamination and the location adjacent to the rectum. They can also be really complex, like you can see in this situation, not always sort of simple anterior perineal. And then they don't always have to just be in the anterior pelvis. From the side of the pelvis, they can also be on the dorsal or the posterior aspect as well. And some of these are, open injuries like the one you see here. And they can also be closed injuries. The closed degloving injuries, like you see on this CT scan, the extensive bleeding that occurs in the layer between the fascia and the fat can often really complicate matters for us as well, and even push us to choose what we're going to do. The second O, other than just open injuries, is obesity. This is a current pandemic as well. If you ask people that are taking care of trauma patients, there are numerous pandemics, and I think currently obesity is, at least in our patients, is a pandemic as well. And this makes things difficult. You can imagine if you're trying to do a surgery on this patient and you pull that abdominal area up, that's an intertriginous zone. It'll be contaminated with a chronic fungal skin infection. All of the different impacts that the obesity has on the host as well, just physiologically overall. The third O, besides open injuries and obesity, is just the osteology. And this is a patient I took care of recently. And, she's a 92-year-old lady who lives alone. And she walks about 2 miles a day and takes care of herself and does all of her chores and everything on her own. But she fell and was on the floor for about 3 days because she had an unstable pelvic ring injury. And her problem is that she's got an unstable ring injury. My problem is I can hardly see her bone. So the CT can see it, but in the operating room, the fluoroscopy unit becomes quite challenging, because being able to visualize the radiographic landmarks that we need really can put quite a hurdle for us to try to get over, especially not necessarily trying to just get a screw in, but get it in safely and accurately, and then also give her the sufficiency of fixation that she needs. I think the one osteological problem that a lot of people are very aware of is this transitional vertebra, the upper sacral segment, or this segmentation issue of the upper sacral segment dysplasia or dysmorphism of the upper sacral segment, which changes the osseous fixation pathways of the upper sacral segment, so that it makes it much more complicated from an imaging standpoint, as well as from a fixation standpoint, to locate safe screws within that. And understanding the osteology, I think, takes a lot of time. And the time that we put into it, in the upper row, you can see what we consider normal sacral morphology, or normal sacral osteology, where especially if you look to the far right, when we see the outlet image, you can see the upper sacrum is recessed relative to the iliac crest on the horizon. And also you can see the exit sites for the nerve root tunnels in the upper and second sacral segment are really circular. And then when you look below it, especially on the outlet image, you can see the upper sacrum is elevated relative to the non-dysmorph. The upper sacrum disc level is usually collinear, just about collinear with the iliac crest. You can see the residual disc between the first and second. You can see the acute alar slope, the residual transverse process that looks like little bumps on the back, the posterior cranial aspect of the ala. You can see all these things. When you move over to the inlet view, you can see the indentations of the upper sacral segment relative to the second sacral segment, this anterior radiographic landmark. So I think as you become more and more familiar with dysmorphism, you realize it's more and more common than we initially thought, and it has a big challenge to us for locating our implants safely. The other problem is just that the bone is curved. You know, the pelvis has got some tubes within it, these osseous fixation pathways that we use, but the curved bone makes it sort of difficult for us, because like nailing a femur, we'd like the tube to be relatively straight, and for the pelvis, it's not always straight. So then we have to resort to surface implants or plates in order to provide the stability that, if we would have just had maybe a curved implant, we could have accommodated that bone pathway. So moving from the patient as the challenge or the problem, we move over to ourselves. And typically I'll teach you that one of the things I've learned very quickly is that pretty much 99% of the time when I have trouble, it's the person in the mirror, and it's not someone else's fault. And so the surgeon has to really learn a lot of things in order to do this. And you know, when I started, essentially there were very, very few people treating pelvic fractures operatively, and there weren't very many. And as time's gone on, of course, people have gotten more and more interested in, so that the volume of surgeons has escalated and the volume of patients has escalated a little bit, but you start to have the experience mismatches more and more go. But we have to look at ourselves, if we're kitty cats, not to see a lion. And we also have to realize that we may not be as smart as we think we are. And we all maybe see ourselves as Einstein, but we certainly are not. So one of the problems, there are numerous problems that we have as surgeons. And one of the problems, the main problem, is just understanding the injury patterns. One of the things I think we all try to do is compartmentalize them into the Young Burgess classification scheme. And our patients just don't read the books. And unfortunately, so many patients have injuries that don't really go along with these classification schemes. And sometimes I'll tell you, this patient you're seeing right here, it took me about 4 hours to understand her injury. And then I'll also tell you that it was her father that pointed out to me that with a question, he just said, do you think that the right side of her pelvis displaced so far that the front part of her sacrum caused the fracture on the inner surface of her ilium there? And, you know, I hadn't thought about it until then, but then when I looked at the two, it was like, yes. So we really shouldn't have to have our patients' parents teach us about the injuries that we're looking at. But we have to work harder to understand the injury patterns and go beyond the books and beyond the chapters of what we've been taught. The other thing that is really difficult for surgeons over the course of my career, probably the most frustrating for me, was just listening to people defer and ignore and not accept or identify instability. Instability, at least in the 90s and 2000s, was anything that I didn't want to treat was stable, according to most surgeons. And I think as time's gone on, people are now a little bit more objective about instability and what is instability. But identifying instability is still something that I'm afraid most orthopedic residents, when they finish their training, aren't really adept at identifying instability. Certainly when you see it or feel it, you can easily accept it. And if you'll listen to your patients, almost always, if the patient's awake and alert, they can tell you if they have an unstable pelvis or not, because they hurt so darn bad. So we have to listen, and then we have to seek this instability. And we can't just look at a plain film like this patient right here. You can see she's got minimally displaced ramus fractures and maybe a hint of a sacral fracture, but she was involved in a high-speed automobile accident. If you just examine her under anesthesia and put about 5 pounds of pressure on her left hemipelvis, you'll see that she has a significant amount of collapse. At least in her opinion, that's significant and would warrant fixation. Same thing, I think, happens even more commonly for elder patients who fall and have lower energy fracture. I think a lot of these patients get neglected, and I think a lot of people are hopeful for stability. And you can see these parasymphyseal ramus and sacral fractures that the patients have, and with a little bit of pressure, this is only about 5 pounds of pressure, you can see the instability. And this patient can tell you she's unstable because she won't move in the bed at all, and she's a very active 72-year-old lady otherwise. The other thing is not just accepting the instability, but also understanding fixation. This has been a real task as far as my career's gone on, is just trying to get people to understand the foundation of fixation, the biomechanics of fixation, the value of reduction, and then the value of stability at each point of instability, not just plating the symphysis pubis and hoping that the posterior ring would be okay, or fixing the sacral fracture and hoping that the anterior ring would follow, but actually understanding the injury to the point where you would understand the mechanical need of the unstable ring. So we've learned over, I would say, the last 30 years, so 40 years, that the value of site-specific reduction and site-specific stability. So unstable points need to be reduced and fixed regardless of the technique that you use. I think people sort of get it, they try to understand, and then you get into these situations where physicians and surgeons are just, they may be forced into situations where they're taking care of patients that they may or may not be really comfortable taking care of, and they end up just like in this situation, pretty much just tossing the kitchen sink at an unstable ring, and all it does is just fix a malunion and also then infect the soft tissues. So this patient ended up, of course, with numerous infections and a malunion. So that's not quite understanding the injury and not quite understanding the mechanics and the principles of fixation. People try to keep things simple, slipping a plate across the back of the pelvis. It's flexible, and putting on a 2-pin frame is pretty simple for the physician, for the surgeon, but it really is not so great for an unstable ring that'll just deform and just overpower simple fixation. You can't put flexible plates all by themselves in the posterior ring when they're unstable and hope that a 2-pin frame is going to offset that. That just doesn't work. We've also learned that frames aren't so great at holding on to ligaments, healing. You can see this patient wore an external fixture for 8 weeks. And this is her film immediately after having her X-fix taken off when she started screaming in the clinic. And you can see that her symphysis that used to be reduced is no longer reduced, even though she's had 8 weeks to try to heal this. In the early 90s, we didn't have a lot of implants. We had the 2-hole 4-5 narrow DC plates. And you can see this is probably around 1991 or 92, because there's some cannulated screws in the back there. And those were when the cannulated screws first came out, the lag screws. But you can see using a 2-hole plate in the front part of the pelvis and not a lot of fixation, the posterior ring caused the right hemipelvis to just twist right around the left pubic screw. So we saw this mode of failure, as well as spreading of the screws, rotating and flexing of the hemipelvis when we use the 2-hole plate. So when the recon plates came out, of course, we thought that was going to solve things, more screws on each side. But in reality, if you still underpowered the fixation in the front end or the back, you can see, we would see the plates sometimes just start to deform and or loosen as a result of the screws getting loose. And then sometimes you could see also, especially with early frisky rehabilitators, you'd see early fatigue failure of the implant in the front because of the thickness and the width. Some designers tried to change that, but in situations the plate wouldn't break, the screws would just destabilize. We started out with ramus fixation using 3/5 screws and quickly realized that 3/5 screws, especially with underpowered posterior ring fixation, wasn't sufficient. We went to 2 sometimes, and the hemipelvis can bend 2, especially when the posterior ring fixation is not so much. And then even with 7/0 screws or bigger screws in the front, if we don't really dock them into stable bone, if we just sort of put them into the parasymphyseal area, that's not always going to hold on to things. We also learned a lot about the ramus, at least when I was learning, when I was a resident, I was taught that all ramus fractures were stable, and then you see patients get fixed, and then you see in situations like this where the one site that was left unfixed is where they deformed through, and then the other fixation in the posterior ring was torn up as a result of it. So we realized the might, if you will, or the relevance of the ramus fixation. And you can see that we still have trouble with the elders, regardless if we have long screws in certain situations. And then we have situations like this where we have a really unstable C-type injury with this patient's right sacral fracture and parasymphyseal left ramus fracture. And you can see the open reduction that's occurred in the percutaneous in the back. The reduction looks great, but she comes to clinic at her 9-month anniversary, with right-sided buttock plane. She has no idea that her screws are all disengaged in the front, and all she knows is that her right buttock hurts really badly right over the head of that screw. So we still have trouble getting stable fixation. And then, of course, we see people like this with all of the screws. These are our frisky rehabilitators. And finally, I just want to finish from the surgeon standpoint, from our standpoint. We really have to understand the techniques involved, whether we're plating a symphysis or clamping a ramus or doing a closed manipulative reduction or identifying instability with an exam or reducing the iliac fracture, whether it's the crest or whether it's a ring destabilizing iliac fracture, or the reduction either closed or open of sacroiliac joints from the back or from the front, and then sacral fractures. We have to understand all of these exposure techniques, these reduction techniques, the timing, the sequencing. And then once we get it all reduced, we have to be able to safely apply the implants. And if we don't understand the osteology, like we talked about, and its fluoroscopic correlation, we can't just sort of poke around with a wire and hope that we're in good shape and then bring the O-arm in and spin it and see if we got it right. It's just not pin the tail on the donkey. That's just not what we're doing here. This is put the screw in the patient, and it's a completely different game. So we have to be really precise. We have to know what we're doing, and we have to pay attention to these osteological landmarks that we're dealing with. So realize that we've just sort of touched on the drip of the tip of the iceberg as far as challenges and problems go with pelvic ring injury and fixation. We didn't get into resuscitation or imaging or all those different things, but this is just a quick little snippet of some of the challenges and the problems that we face. And so I'll tell you, all of this stuff is, you can command it all. It does require, I think, extra work. It does require, a pretty good passion for it and some focus to it. But this information is all available to you. And I think you'll learn later on that there are devices that are still being made that are trying to make things a whole lot better. And so, it doesn't really matter to this ram what the fall is. He just knows where he's got to go and what he's got to do, and he's prepared for that because he's done it before and he's learned how to do it. And so the risk is still the risk, but he's completely safe knowing what he's doing, how he's doing it, where he's going, and how he's going to get there. So, and then I won't get into the institution. So I appreciate your attention. Thank you for having me. Now I would like to hand it over to Dr. Robert Meek, the visionary behind this unique tool for pelvic fixation. Take it away, Dr. Meek.
Thanks, Chip. I'm going to talk about the development of a new curved fixation device from a surgical perspective. I should first say my conflict of interest. I'm a senior member of the Curvafix team. Myself, my university, and my hospital all have a financial interest in the success of Curvafix. Of course, this is not a surgeon thing alone. There's much other things, money, engineering, corporate expertise all needed to do this. But this fixation device is basically for the pelvic ring and for the anterior and posterior columns of the acetabulum. Dr. Rout has already talked about some of the fixation problems in the pelvis and shown some examples. So I'm going to talk more about the theory of the fixation and the development of the new device. So I think that cannulated screws in the pelvis are basically a form of intramedullary fixation. The forces are often perpendicular to the screw. The intramedullary fixation we know from femurs and tibias is a good form of skeletal fixation. It works best when the canal is stuffed or filled. It's not so important if you can lock it at both ends, but that's more difficult in a curved situation. And it's better if it's a long, strong, wide device. If you're going to use compression, then you have to be perpendicular to the fracture if it's a narrow device. But if the device stuffs the canal, then you can compress it without any displacement of the fracture. So posterior straight screws act as an axle. One hemipelvis can rotate on the other, and then the screws can loosen, as you see here. So if you imagine this device being up in here, you can't rotate it one hemipelvis on the other, because if you tried to rotate this end would rotate, and this end would then have to dig a tire-shaped hole over here in the ilium. So that's not possible. It's also can't be pulled out because it's curved, and it's not really it shows a C curve here, but it's a bit of an S curve. And if you pulled as hard as you could, you would not be able to pull it out. To pull it out, you'd have to be able to pull it right through the bone, and that's not possible. So the idea is to stuff the medullary canal, in this case posteriorly, in this case down the anterior column pubic ramus, and in this case down the posterior column, with a large curved intermedullary rod. So if you try to use a straight device in a curved bone, you get into this difficult situation where you have this curve and you put your straight device in, but it won't go very far across the fracture. If you make it really thin, it'll go maybe up to here, but if you make it really fat, it'll only go up to here. So it won't really go very far into your distal fragment. And that's the problem with some cannulated screws. On the other hand, if you have a curved device, you can make it as fat as the inside of your bone and go all the way around the corner, right down to the far end. So you've got lots of fixation in the distal fragment. So we've used this in patients in most of the curves illustrated here, and in cadavers, I think in all of the curves illustrated here. So you can put it in the iliac crest, you can put it from the front to back through the anterior inferior spine, S1 down the anterior column in the pubic ramus. And these are just different views. This is the posterior column. We haven't used it in a posterior column in a patient, but it's very easy. So Dr. Rout's group described the safe osseous fixation pathways. And what we think we have here is curved, safe osseous fixation pathways. The surgical procedure is quite easy for people who are experienced with the intramedullary nailing and with pelvic surgery. So basically we put a guide wire in just like you do in a femur, except our guide wire is curved. You ream over the guide wire to the best possible size, and then you screw in, instead of hammering in, you screw in a flexible cannulated implant over the guide wire into the tunnel you've made with the reamers. So this is the implant curved. It's cannulated here, and it goes in over the guide wire. When we developed it, we wanted it to be flexible. We had to figure out the right sizes, big enough, small enough. We wanted it to be stiffenable, so it could be made rigid, but on the other hand, the stiffness had to be reversible, so it could be removed. And these other things are obvious: biocompatible, cleanable, strong, affordable, and importantly, surgeon friendly. We figured all this out by an anatomical study, which is published. We looked at 100 patients and measured the narrowest choke points in the possible curved tunnels. We concentrated on S1-2, the anterior column, pubic ramus, the posterior column, and we figured out the radius of curvature that we would need to go around. So to measure the radius of curvature, we dropped circles inside the pelvis and then measured the radius of curvature in the various circles where we thought we would want the device to go. We made it flexible to go in and then stiff to once it's in. So the screw end is here, and it's used to pull the device in. The head end is here, and it stops at the bone. The torque transfer happens through the beads because they have this little jigsaw pattern. And when you get it all the way in, if the canal is stuffed, you can put on some compression because the fracture cannot then displace if the canal is stuffed. We measured the length by putting these little splines in various pictures using engineering CAD software, and figured out the lengths we needed. We figured out the diameters we needed using spheres in the CT. So we chose the narrowest point, took a sphere, and figured out that sphere had to fit in the bone in all views. So here's an example of the sphere in the back. You can see it on that view. You can see it on that view. You can see it on that view. And then we would adjust the diameter of this using the CT software to figure out a sphere that would fit here, here, and here. And then that was the maximum size that would fit in the back. And you can use that clinically as well. And we did the same thing down the front, measured the spheres that would fit in the narrowest part in the front. And we came up with this implant you see here. It's flexible. It's lockable. Inside this housing here is a locking mechanism that locks some cables in place. It's cannulated, so there's a hole here that comes out over here. It comes in multiple lengths. From our study, it fits in 95% of patients at the back, including the dysmorphics. It fits in a lot of dysmorphics. It fits in the pubic ramus in 95% of females and 80% of males at the current size. Of course, it took a long time to develop. So where might this be useful? So anywhere you can use a cannulated screw, and some places where a cannulated screw won't quite reach. And I think it can replace 2 cannulated screws with one device because it's long and curved and can't be pulled out and can't be rotated upon, so it can't act as an axle. These other two at the bottom are potentially future things, but we're not quite there yet. So thanks for your attention, and I'll now turn the discussion over to Dr. Medit-Yahoo.
Hi, everybody. My name is Amir Medit-Yahoo. I'm an orthopedic trauma surgeon at University of California in San Francisco. I've been using the Curvafix intramedullary implant for a few months during the study, which we're going to talk about in a minute. We are doing a study called Restore, and the idea behind Restore is basically a safety and technical feasibility evaluation of the Curvafix intramedullary system. This is for fixation of pelvis and acetabular fractures. The sponsor is Curvafix, and the implant is basically a curved implant that can fit into curved corridors in the pelvis. So the study is being done in 6 centers around the US. Our center is in San Jose, California. We're excited to see what other centers are doing as well. The idea of how the procedure is performed is basically just like every pelvis and acetabular fracture, where you're going to put straight screws, but there's some steps to take in order to get the curved implant into the body. So we'll do the video. The first step essentially is to put a guide wire in, followed by an entry reamer. And then the steerable guide wire is placed, and you can curve this to bounce off the cortices to make sure you're inside the bone. This takes a little bit of practice, but after a little bit of practice, you can actually steer this guide wire in dysmorphic S1 segments, which I'll show you. After you put the steerable guide wire in, as you can see, it's curved here in the S1 corridor. You essentially ream over it. And then after reaming, you place an exchange tube. And the exchange tube essentially gives you the opportunity to put a ball tip guide wire, this is the exchange tube. And after that, the implant is inserted. It's inserted flexible and then locked to be rigid after it's placed in the body. So that's basically how it looks. You can see what the entry looks like. This is another one, essentially, again, guide wire placement into the anterior column, followed by an entry reamer, and then a steerable guide wire is placed. Obviously, the imaging, we're going to take our inlet view here, and then operator outlet view, which you're seeing here. And we're going to steer this guide wire so it stays within the corridors that are safe within the pelvis. And then, same steps, reamer over the ball tip guide wire, followed by exchange tube. Now, the key with the exchange tube is that you have to put it all the way to the end of where the steerable guide wire is, because if you don't do that, the non-ball tip guide wire can go in a different direction, and then insertion of the implant. And I'll show you some cases here that we've done over the last few months with these exact steps. So why is this implant compelling? In my mind, the pelvis has curved corridors. You can see from the images, these are images from one of our patients we're going to discuss later, that the anterior column, for instance, has a curved corridor and needs to be filled by a screw or a curved implant. The screw you can put in a curved corridor is much smaller than a curved implant. So the places you can put the Curvafix implant are the anterior column, the posterior column, LC2 screws, which basically go from the AIIS to the PSIS, and into the sacrum. The screws, the way I look at them, they're essentially used like intermedullary nails in the pelvis. There are some screws that are used for compression, but a lot of times what they're doing is basically filling a corridor to hold that corridor in place so it doesn't move. So the better fill you have, the bigger the implant, the stronger it's going to be. Screws can't offer compression. Unfortunately, they're straight, even though the corridors in the pelvis are curved. They can't fill the inner walls of a curved corridor because they're straight. So they can't be as large. And if you look at the bottom two images, these are just a simple schematic showing two curved tubes where a straight implant versus a curved implant, and what sizes you can get into the curved tubes. Another image here. This is a schematic of a cut through the pelvis at the S1 location. And if you look at the left image there, you see that if you put a straight screw, essentially you can only go to about the middle or a little past the middle of the body of S1. And if you had an imaginary curved implant, or a kinked implant, you can put it essentially in the right position from the one side to the other side transsacrally, even with a dysmorphic sacrum. And these are some more ways to look at the pelvis. The upper left is the outlet view, and the bottom right is the inlet view. And corridors in the pelvis again are curved. You can see that with the yellow lines. When we try and put screws in those locations, the screws essentially are small and they can't actually follow the curvature of the pelvis. This is an example of a mildly displaced anterior column fracture with posterior hinge transverse acetabular fracture. As you can see in the images, the fracture essentially is minimally displaced. We discussed with the patient regarding operative versus non-operative fixation. The patient chose to have operative fixation and early weight bearing. So here are the steps of inserting the Curvafix implant. On the left, you see initially a guide wire is placed, followed by an entry reamer. Then the steerable guide wire is placed. And you can see in the middle images here, an inlet view and an obturator outlet view where the steerable guide wire is placed in a curved manner to fit this corridor. There's a reamer that then goes over the steerable guide wire. And then the non-ball tip guide wire is placed over the exchange tube, and then the implant is placed and then locked. And here you can see that essentially the implant is curving to fit within the corridor that is a curved corridor and outside the acetabulum. Postoperatively, the same thing is seen, especially as you look at the bottom right here with the obturator oblique view. This is an obturator outlet oblique view where the Curvafix implant is curved to fit within the corridor and is holding it in good position. Another case of 48-year-old man with possible right hemipelvis instability. There's a slight amount of opening anteriorly. So this patient goes to the operating room for a examination under anesthesia and stress tests showing opening of the right sacroiliac joint, as you can see on the image on your left. And the left side does not open. So we see that the right sacroiliac joint and the pubic symphysis are widening under stress. So the patient's taken to the operating room and the front is fixed with a plate and screws. And then we again use the Curvafix implant, initial insertion of the steerable guide wire after opening reaming in order to fit the implant within the S1 corridor. And you can see on the left there, that's what the entry looks like for the entry reamer on this intraoperative CT scan. And then the guide wire is placed in the correct location, followed by reaming, exchange tube, a non-ball tip guide wire. And then the implant is inserted, and you can see that it follows the guide wire, but actually follows the inner walls of the corridor of the sacrum in this location. And that's why you see some curvature of the implant as it basically moves its way through the corridor to stay within the bone. So then we detach the insertion device after locking the Curvafix implant. And here you see it with the outlet view on the left, how there's a nice curvature right at the point where it's probably the most dangerous, which is around the S1 foramen on the right side of this patient. And on the right side, you see on the right image here, you see how the Curvafix implant is inserted and flush to the outer wall of the ilium. 6 weeks post-op and 6 months post-op. No change in implant. The bone is healed. The patient is walking without any difficulty. Another patient, this is a patient with an APC3, so anterior posterior compression type 3, with complete instability of the pelvis. He has a pubic symphysis dislocation, a left ramus segmental fracture, a zone 3 sacral fracture that can be seen on the CT scan on the right here, and a dysmorphic upper sacral segment. So S1 is dysmorphic. And he also has a distal radius fracture, which we're not going to really discuss. So these images are showing a very displaced pelvis, a sacral fracture, which is basically a tension failure in zone 3, and some displacement. So my plan of attack for this patient is to first fix the pubis symphysis, hold it in place, fix the ramus, which is segmentally fractured, which is what we would do initially in order to help to reduce the posterior elements. And then a compression transsacral screw followed by a Curvafix implant that is placed through the S1 upper sacral segment. And what you see here essentially is initial on the bottom left wire, an entry reamer, and then the ball tip steerable guide wire is placed through the S1 corridor, which, as you can see, is essentially curved in order to stay within the bone. Then reaming, followed by exchange tube, as you can see on the right. And then the Curvafix implant is placed over the guide wire transsacrally in S1, which is dysmorphic. And this is pretty much impossible to do using a straight implant without dysmorphism like this. Intra-op CT verification showed the sacral fracture to be anatomically reduced, and you can see the Curvafix implant within the S1 corridor in the right location, both on the two upper images here. The bottom image is just to show the S2 corridor with a straight screw. That's what it looks like post-op. 3 months later, no change in movement of the fractures. They are essentially healed, and the Curvafix implant is in good position and hasn't moved. Last case, 24-year-old girl who had a right sacral fracture, again, dysmorphic S1. And it's tough to see the fracture here, but you can see, at least in these images, that she has superior and inferior rami fractures. And then if you look at the intraoperative, at the pre-op CT scan, you can see a zone 2 sacral fracture with marked dysmorphism of the S1 corridor, which can be seen almost in every image here. So again, the steerable guide wire is placed after opening reaming. This is the outlet view here on the left, showing how the steerable guide wire can be curved to fit that corridor. And then you see reaming on the right here. And then in this particular case, after the exchange tube and the guide wire is placed, the implant essentially curves and stays within the bone, both on the outlet view and, as expected, in the inlet view, because it's obviously a three-dimensional anatomy that is dysmorphic. So if you look at these are the last two images. You can see how the implant is essentially curving to be in the right position on the outlet view, and then if you look at the inlet view, it's moving posteriorly to stay within the sacrum. This is post-op. So, my current experience, I've been able to put these screws in S1 and S2 corridors. I think they're very helpful for dysmorphic upper sacral segments and as antegrade anterior column screws. My personal findings are the entry is much more forgiving than a straight screw, because the steerable guide wire can be moved to stay within the corridor that you're trying to be within. The sharp ball tip guide wire, the steerable guide wire, does take a little bit of time to figure out how to use, but once you figure it out, it's pretty easy. I have not used this implant for compression as of yet, and this will be hopefully forthcoming. So thank you very much for your time. Looking forward to your questions.
Thank you for including me in this Curvafix discussion on pelvic ring injuries. I'd like to share a case of a complex patient with a relatively simple pelvic ring injury, but some of the decision-making around this patient, I think, presents an opportunity for discussion. This is a 40-year-old female who was struck by a vehicle. She's a polytrauma patient, and I'll go through her injuries very shortly. Her past medical and past surgical history is consistent for a prior left below the knee amputation. Interestingly, her prosthetic limb that she was wearing at the time of the accident was crushed by the tire involved in the motor vehicle. She has also had a C-section ×2. Her social history that she occasionally uses tobacco. She is the sole caretaker for a child with needs, and she works as a cashier. This is her chest x-ray. There's a couple of things that come up on this chest x-ray. Number one, for the orthopedic surgeons, there's a proximal humerus fracture on the right. Always an opportunity to remember that the chest x-ray can reveal additional information. I share this x-ray with you because I did not see dedicated proximal humerus films on our system for the right side. The chest x-ray also reveals multiple root fractures on the left, consistent with a flail chest, and she clinically was symptomatic from her flail chest. The left upper extremity has a left proximal humerus fracture, along with a distal intra-articular humerus fracture that's comminuted of the elbow joint. So again, both extremities are injured, and she has the flail chest. This is her AP pelvis. Again, remember, she's got a below the knee amputation already on the left, but this is her AP pelvis with a right-sided sacral fracture, a right-sided parasymphyseal injury, and the radiologists did not point out with their arrows a right-sided superior pubic root injury as well. She also has an inferior ramus fracture on the right. The arrows were from our colleagues in radiology. Here's the CT scan of her pelvis, and you'll see that there's a sacral fracture along with the injury to her anterior pelvic ring on the right. Again, individually, this injury is not catastrophic, but as we think about this polytrauma patient, she has a right-sided sacral fracture, a right superior pubic root injury, and a parasymphyseal fracture. She has a right proximal humerus fracture, a left proximal humerus fracture, a left intra-articular distal humerus fracture, a flail chest, and a below the knee amputation that's healed, but she has no prosthesis. So as you think about these injuries and the goals of care for her, we had a lengthy conversation with the patient about treatment strategies. She's made it clear that she needs to be early weight bearing given her social situation, where she needs to be at home and not going to rehab, and she needs to be able to work sooner rather than later. We also discussed her pelvic ring injury and her weight bearing status, recognizing that the left side did not have a prosthesis, so she'd be unable to really put weight through the left leg until her prosthesis became available in approximately 4 weeks. And on the right side, she has real pelvic ring fractures. And while you might consider letting her use some kind of protected weight bearing, with both upper extremities injured, that's going to limit her ability to use things like crutches or a platform walker. And so being able to put the majority of her weight through her right leg was an important consideration in her overall treatment. As a result, we went ahead and worked with our trauma colleagues. They fixed her flail chest. This is their post-op x-ray from the flail chest fixation. Myself and my colleagues fixed her right proximal humerus, her left distal humerus, and her left proximal humerus. So her upper extremities have been stabilized such that she'll be able to weight bear through her limbs in conjunction with pelvic ring fixation. The intent of fixing her pelvis, in my mind, was to allow her to be immediate weight bearing. My challenge, of course, is how do I fix the parasymphyseal injury and do it in a relatively minimally invasive fashion? I find putting a screw percutaneously to that parasymphyseal region doesn't really provide a tremendous amount of stability. And obviously fixing the posterior pelvic ring is important as well. You'll see here on this lateral image that I've localized my guide wire. It's posterior to the iliocortical density and anterior to the S1 tunnel. This wire was positioned after getting appropriate inlet and outlet views and passing my wire just lateral to the border of the S1 tunnel. After positioning my wire, I used an opening drill to drill the lateral cortex, and then used this guide wire, which has a curved tip to it, and was able to get this across her entirety of her posterior pelvic ring. Again, I wanted stable fixation in the back of the ring so I could allow her for immediate weight bearing. After completing positioning of my guide wire, I then reamed and then placed a Curvafix screw in the posterior pelvic ring bilaterally. You can see the S1 tunnels in the picture on the left in that outlet view. And you can see the screw safely traversing across the posterior pelvic ring. I then turned my attention to the anterior pelvic ring. Again, I wanted to fix the back and the front of her ring so that she could immediate weight bear. And you could argue fixing the posterior pelvic ring would give her anterior stability, but I wasn't sure, given the fact that she had the superior pubic root and the parasymphyseal, getting good stability across the anterior ring would reassure me that there would be no late displacement. Here you can see me localizing my starting point for my anterior column screw. And this is a challenging screw to put in, I think, because you have to get your trajectory just right to get down that narrow anterior column. In this scenario, using the Curvafix device, I was able to position my wire without that specificity necessary in using a device that may not be like Curvafix. I then positioned, that was with a small diameter Kirschner wire. I then used the appropriate sized wire by swapping it out, and then use the entry reamer that you see on the left, followed by that ball tip guide wire. That ball tip guide wire has enough flexibility to be able to get through a narrow tunnel and enough rigidity that it will pass through the cancellous bone. You can see the parasymphyseal fracture, and as I approach it with that guide wire, my goal was to get that wire across the symphysis so that I could bridge that parasymphyseal fracture as well. And you'll see that wire is able to get into the far symphysis across the symphyseal joint. You'll see here that I've now done an exchange tube, and I've reamed to get my screw in. And there's the reamer going down the anterior column, following the curvature of the anterior column, and all the way across to the other side of the symphysis. So I'm able to get that screw in the parasymphyseal region of the uninjured side to dock it to give it stability. That's our post-op AP pelvis, showing the posterior pelvic ring fixation as well as the anterior pelvic ring fixation. At this point, both her upper extremities have been fixed. Her right-sided pelvic ring injury has been fixed. I've allowed her to be immediate weight bearing on the right leg post-operatively. She was awaiting her prosthesis on the left side, but she was using platform crutches in the right and left upper extremities, along with full weight bearing on the right leg post-operatively. She was able to go home after several days, as she had a number of surgeries, and she actually returned to work 2 weeks after being discharged from the hospital. She was using a scooter type device for her left lower extremity that had been amputated. This is her at 6 weeks. This is our most recent follow-up. She has been full weight bearing on the right lower extremity. You can see that the hardware is intact. She has some heterotopic bone at the site of entry of the anterior column screw. And she appears to have good healing of her anterior column fracture, or her parasymphyseal fracture, I should say. The posterior ring appears to be stable, and the inlet, outlet, and AP pelvis views don't demonstrate any late loss of reduction, despite her being immediate weight bearing on that hemipelvis on the right. Thank you, and I look forward to discussing this case as well as the Curvafix device.
Good evening, everybody. My name is Carl Van Osten. I'm the Director of Orthopedic Trauma at North Mississippi Medical Center in Tupelo, Mississippi. Thank you to our previous presenters. I'm happy to be here tonight to share my clinical experience with regard to the Curvafix implant, and will present an acetabular fracture in which the implant was used. So this situation, this patient was a 28-year-old male involved in a motor vehicle accident, and he complained of left hip pain. He had no other significant injuries that needed to be addressed, and we were consulted. The sequence of events we're going to discuss will show us how we got from his preoperative film on the left to this postoperative film down here on the right. So injury film again, basically AP pelvis shows left hip fracture dislocation. And you can see the posterior wall or portion of the posterior wall component of this injury. This patient had his hip reduced by our emergency department, and we placed him in some traction. The one of the post-reduction films shows more of an obturator oblique view and shows a hint of the transverse component of the fracture and possibly some joint space widening, maybe some fragments in the joint. So the CT scan confirmed essentially transverse posterior wall fracture pattern with a very comminuted posterior wall and some osteochondral fragments in his joint. One thing to mention here is this transverse component of this fracture is not significantly displaced. And I felt this would be a nice opportunity to try to utilize this novel implant in this situation, especially with a sort of a minimally displaced fracture, and felt it would be a good indication for a percutaneous type fixation of the anterior column in this particular injury pattern. So he was taken to the OR when he was stabilized. We placed him prone on a flat Jackson table and proceeded with a Coker-Lange back approach. We used a large femoral distractor initially to distract his hip joint and remove all those osteochondral fragments in the joint and put them aside to later reconstruct the posterior wall. The transverse fracture, as mentioned, was fairly well aligned, especially after those fragments came out of his joint and his hip was reduced. The anterior column component was additionally reduced and compressed. I like to get it as anatomic as possible and compress it and hold it until the fixation apparatus is into the column. So there's a standard sort of angle jaw through the sciatic notch and standard location, compressing the anterior column component of the fracture. We then try to get our start point for this device, and you can see the guide wire in the obturator outlet view and the inlet view. One thing to note here particularly is that guide wire is not perfect as far as where it's aimed, especially on that obturator outlet view. And if one was doing a straight implant, it may be sort of difficult to, if that was the guide wire, and imagine you were trying to do a long 6/5 screw, it may be difficult to accept that trajectory and that start point to continue to get adequate fixation in this circumstance. So with that guide wire in place, as mentioned, if you look at that fluoroscopic image on the left, we're potentially not satisfied with that if we're using a straight implant, but this technique calls for a few centimeters of opening with a step drill or the opening reamer, if you will. And in this situation, obviously that was very adequate. The next thing is the cannula and the steerable guide wire. And as you can see in the second image, it's very easy to then manipulate this steerable guide wire and turn it with a T-handle to whatever direction is necessary to remain within the safe osseous pathway of the anterior column, as it has been described. And this guide wire is then scooched along in millimeter increments by tapping this T-handle. The guide wire is very thin and flexible and can kink if you're not careful to choke up a little bit with that T-handle, but it is otherwise very easy to turn it and manipulate it. And you can see as it progresses along over to that inlet view, showing its progression. So our final placement of the steerable guide wire for this case, and I felt this was fairly straightforward to do and was fairly easy, and was very happy with that. Was very interested to see that it was very curved, and that's obviously, I think, a good thing for this implant. Was very curious to see how that implant would follow the curve of this guide wire. So the reaming is next, and reaming is carried out over this steerable ball tip guide wire. And you can see the progression of this in several views. And the reaming was carried out in this particular circumstance up to the diameter of the body of the screw, which was 8 millimeters, while leaving the tip or the area where we were hoping the cancellous threads would get purchased, slightly under reamed, and making sure not to over ream that very end of the pathway here. So after the reaming was carried out, the implant was inserted. We took 20 millimeters off our measurement as is described by the technique. The reduction was maintained with that clamp until the implant was in its final position. And as I mentioned, it was kind of nice to see it go in that curved fashion. One thing to mention, obviously, is you'll see that guide wire is different. That's after the exchange tube is used. The exchange tube needs to be inserted fully. So you can pull the steerable ball tip guide wire out and put this straight wire in, but the straight wire will come out the very end of where you want it to come out, and not come out too early of the exchange tube and create its own new pathway, which would, I think, be just a sort of technical oversight. But this is the screw going in. Here's the screw, some other good fluoroscopic views of that screw as it's going in and then subsequently being locked. The obturator outlet, another inlet view. Here's the final position after it was locked using the torque handle and tensioning that internal wire and converting it to a rigid implant from a flexible implant. The clamp was removed, and then this curved implant that is stuffing the bony corridors, as was described by Dr. Meek, is in position and is now no longer flexible but stiff, and is completely filling this pathway and therefore maintaining this reduction which was obtained. So after the intercolumn Curvafix screw was placed, we continued onward with the rest of the case and repairing the rest of the injury with some more standard posterior column plating, and then buttress plating and spring plating, et cetera, for repair of all the osteochondral fragments and repair of the posterior wall injury. So these are just our fluoroscopic images showing what we ended up with, basically AP and obturator outlet and an iliac oblique view. So here are the post-op films. Again, some standard views that would be obtained, showing, I think, a reasonable reduction in a good construct for this injury. Very pleased with the position of the Curvafix screw in these images. We did use a 110 millimeter Curvafix implant, which was 20 less than the measurement at 130, and it really turned out, I think, just perfectly as it was seated. And seated, almost ideally into the countersunk area of the ilium, and still had some purchase from the distal cancellous threads. So at 10 weeks, this patient came back to see us. He was doing very well. These were his images. He was weight bearing as tolerated at this point. He had been slightly non-compliant, which is, I think, obviously not great. I think he started weight bearing maybe around 5 or 6 weeks, and I may have waited a little bit longer with that comminuted posterior wall, but he was doing well. There were no issues at this point. He had full range of motion, no complaints, no pain, and was wondering why he would even need to come back again and see us. Some summary points for this case and my experience overall. This was the first case I actually did with this implant, and some things jumped out to me pretty quickly. It is a much more forgiving start point. I think we sort of discussed that during the case presentation. In fact, I think potentially a more eccentric or not perfect start point might end up being a very good thing with this particular type of implant. And as I've done some posterior pelvic ring cases, I've experimented with different start points that will allow the implant to actually curve more, as obviously we don't need to be straight on our pathway with this implant, and having it curve and stuff these osseous pathways and then become fixed, rigid, and locked is going to provide even more stability and fixation and holding power. The steerable guide wire does allow for some tactile feedback. I think it's nice. You can turn it with the T-handle and feel it scratching, quote unquote, along within the osseous pathway, as one of my scrub techs is very fond of saying. The tactile tactile feedback rather is also very, I think, interesting, because when reaming, it's almost like you're reaming a long bone. You can feel the chatter, quote unquote. And this to me was an interesting experience, reaming an osseous pathway of the pelvis, and you can follow it on fluoroscopy, and you can feel the reamer chattering along that that osseous pathway, and it does sort of give you that additional feedback that you're within that contained, safe osseous pathway. The curved implant follows the curved bony corridor, which is obviously the idea. And then it stuffs that bony corridor, and then it's locked into place. And if one has a good reduction, and the implant is then curved and stuffed in and locked, it's in my opinion, a really nice way to maintain that reduction. One thing to think about is, I think Dr. Meek mentioned a little earlier, was also that they have done many studies on the appropriate sizes of the implants, at least the initial sizes that would be released, and found that this was this size would cover most situations, but it would maybe be too large, I guess, for a potential situation if you had a small female or something, and just to be aware of that. But anyway, thank you for letting me present this case, and I will now hand it off to the next speaker.
Well, thanks, Dr. Van Osten, and excited to be with you tonight. So I'm going to present a case where I use the Curvafix for percutaneous superior ramus fixation for a medial fracture with an antegrade device. I did this case last spring in Houston, Texas, before I moved out here to Los Angeles this summer. So the case is a 32-year-old female. She's been in a motor vehicle collision. She's polytraumatized. She has a splenic laceration. She has left superior and inferior ramus fracture, a left posterior crescent fracture, and then a posterior cortical fracture of the right superior ramus. She's also morbidly obese, and then she does have pain with internal rotation and bilateral hemipelvis. And so here's some imaging. You can see on the right 3D surface rendered images with inlet and outlet views, and you can see the superior ramus there on the left side, which is medial to the obturator foramen, and then the posterior cortical buccal. And then you can see an outlet image. We see signs of sacral dysmorphism here that you can see with the upsloping sacral ala, mammillary bodies, and the inability to get transsacral fixation at the upper sacral segment. Here's her axial CT scan. You can see that her soft tissues are abundant. She's obese, like so many patients are these days. She had an L5 transverse process fracture, a posterior ilium fracture. And then as you come to the anterior ring, you can see that medial superior and inferior ramus fracture on the left side, and then the posterior cortical fracture of the superior ramus on the right. She also had a proximal thigh wound. You can see some of the air there that did not communicate with her fracture. So I think we could all talk about the merits of stabilizing some of the more minimally displaced fractures. That's probably a talk for another day, because I think it's still controversial. But she did have pain. We talked with her about risk and benefits of surgery, and she wanted to have an EUA and fixation to limit her pain and for early mobilization. So here's her imaging here. So here's what we did. Here's her EUA. She did not have a ton of mechanical instability, but you could see that there. With her pain and with the discussion, we did elect to go ahead with fixation. She was supine on an OSI flatbed. We had a central sacral bump for her. So we get our starting point with the standard views that we're all familiar with for the anterior pelvis and superior ramus. We did obturator outlet imaging and inlet imaging. You can see our guide wire starting there, and then our entry reamer going in, creating a path where we're going to be outside of the acetabulum. We'd measured her preoperatively. But there are two constriction points within this corridor, one above the acetabulum and one above the obturator ring, and both measured out to about 9 millimeters. So we felt, especially with a curved implant, we'd have an ability to get the 8.0 millimeter rod screw in. And so here you can just see us working and advancing. And here we use the tube and the ball tip guide wire. But one thing I've found difficult in the cases I've done is sometimes this wire is too flimsy to advance through more dense cancellous bone. So you can see a way I've kind of overcome that is this is going back to a Synthes 6.5 or 7.3 millimeter cannulated screw set. And that's a terminally threaded 2/8 guide wire, which is a little bit more rigid. And we're able to place that and then use a 5.0 cannulated drill bit over that wire to advance and create more of a path for the ball tip guide wire. So you can see here, that comes out, our ball tip guide wire goes back in, and here you can see it's heading anterior and would exit out the anterior ring. So we proceed on, and then you can see us using the turn of the bend in the guide wire to accommodate that canal and enter the metaphyseal bone of this medial superior ramus, which can be very difficult to get. You can see the bend in that wire on the inlet image and how anterior you would need to start. Sometimes to get a screw antegrade into this bone, you may be in the iliacus gutter, just lateral to the iliopectineal eminence. And so there you can see the wire seating, going into the metaphyseal bone, and you can even get past the cortex. Here you can see us preparing to ream. There we're measuring. I think measurement's still a little bit of a challenge with this device, getting it precise. But then we proceed with the reamers. Here it is on an obturator outlet image. You can see the countersink going in. You can see the exchange tube changing out to a non-ball tip guide rod. And here you can see the rod being inserted, or the rod screw being inserted past the acetabulum, past the obturator ring, and then docked there on an obturator outlet image. And you can see we have nice length. I'd actually like this to be 5 millimeters longer and get that cortex of the medial bone. You can see it here on the inlet image and how the curve allows us to accommodate this corridor. And we tension it down. And there's a final inlet image, final obturator outlet image. And then we just proceed on to the posterior ring. She's a dysmorph, so you can see the indentations, inlet and outlet views. Also use of a hyper inlet view to ensure we're not too posterior that you see there. And then here more of a transsacral style screw, but we didn't take her other joint given the minimal displacement and the stability after fixation. So here's our post-op CT scan. Where you can see the posterior ring will have safe screws in the upper sacral segment and the second sacral segment that are extraforaminal. You'll see the rod screw there docked, being extra-articular for the acetabulum, staying within the superior ramus and entering that medial bone. Our general surgeons wanted to manage her thigh wound, and that's a Penrose drain there, again, separate from the fracture. Here are filmed 6 weeks post-op with AP inlet outlet views. She was made weight-bearing as tolerated with a walker immediately after surgery, had pain resolved by about 3 or 4 weeks and did well without any clinical events. So I think the take-home points for this, I think this is a really good implant for the superior ramus. I would love someday to see this smaller than 8.0 millimeters because there are a lot of patients who don't have anatomy or osteology to accommodate this size implant. This patient did, but measured at 9 millimeters. But I do think the curve can be beneficial, especially with antegrade fixation to get into a more medial superior ramus fracture. It really helps you accommodate into that bone. I don't know that I'd want to use this device in a retrograde fashion, given the structures and the amount of bone you need to take out. But antegrade, I think this is a good potential solution.
Thank you to all of our speakers for an excellent program. And most importantly, thank you to all of our attendees for participating in this evening's program. On behalf of Curvafix and today's panel of experts, be safe and stay well.